IT issues taken care of. Let's get started. So thanks everyone for taking part tonight. Speaking now, Stuart Menzies from CTC Communications, with a company that helped put together PACE-MS, which was sponsored, of course, by Biogen. Tonight is a training meeting, actually, where one of our faculty, Margaret Prociuk, who is a nurse practitioner from Edmonton, is going to present the results of the program. Dr. Verinder Bond's online as well, and he's going to provide some input at different elements along the way. And really the objective is to train you on the outcomes of the program so that you can do these programs on your own in your own region, so you can take the results and present them back to your colleagues. So just a housekeeping note, if you've not already, please sign your contract with today's date. You should have received it in an email from Ashley Folkert. Her email address is listed there. It can be docu-signed, it doesn't have to be physically signed, and the contract covers the training meeting and share back sessions following tonight's meeting. So please sign that contract with today's date and get it back as soon as you can so we can ensure you're paid for this training and for your future work. So onto the program. So the PACE-MS was put together by a faculty, including neurologists and a nurse practitioner. So we had Stephen McKenzie from Mississauga, Ontario, Natalie Parks from Halifax, Nova Scotia, Letitia Murazan from Quebec, and Margaret Prociuk, as I mentioned, from Edmonton, Alberta. The objectives of the program, as you'll have known, having taken part of the program, was to map the current treatment landscape in MS, to determine how patients are being sequenced, to understand the profile of MS patients being treated with first-line DMTs, and to determine the drivers influencing the choice of DMT along the treatment pathway. As you'll know, having participated, there were two phases. There was an HCP profile, which is just to sort of get a baseline feeling for how the neurologists practice, and then there was patient assessments. So we had 33 neurologists complete profiles, and 314 patients on first-line DMTs were assessed through this program. I put this slide here because you're going to be presenting it potentially to people who are not familiar with the PACE-MS program, so it's important to provide a little bit of background. So I'm now going to turn it over to Margaret Prociuk. She's going to present the results of the PACE-MS program and some discussion questions there. So Margaret, can you just make sure that you can control the slides now?
Oh, not yet.
Not yet. Let me try your other one. Okay, can you try again?
I don't know how I managed to log in twice. Yeah, that's working now.
Okay, perfect. So please go ahead and present the results.
Okay. So welcome, everybody, and thank you for taking time out tonight to join us. So I'm just going to review the slides and go through a little bit of the information well, I'm going to go through the information that we gathered. So as Stuart had mentioned, we had 33 neurologists involved in this, and you can see the breakdown here of the different regions in Canada. So 36% Ontario, 39% Quebec, 9% from the East, and 15%. And what it looks like is that 42% of people were solo practices, but 64% of all of the people that were involved were considered themselves MS specialists. And 79% of them had nursing support sometimes or always. So a really interesting group, but really considering themselves MS specialists. And you can see in the bar graph on the right that over 37% got over 50 MS patients per month. So quite a large cohort of patients were reviewed. Sorry, I'm just checking. So how they worked it is they did a hypothetical patient case. So this is probably not an unfamiliar presentation to yourselves. It's a young lady named Katie, a 27-year-old female insurance clerk, referred to you by ophthalmology with an episode of sudden darkening of central vision and inability to read affecting the right eye occurred about 2 months ago. So she was treated with IV steroids for 3 days and now feels that her vision is back to normal, able to see the computer screen and read. An inquiry recalls a 2-week episode of right-sided paresthesia, including her face, that occurred just over 1 year ago, which she also fully recovered from. There's no outstanding family history, born and raised in Canada. Her neurological exam is there. Doesn't really show anything really exciting. She's got an EDSS score of 0, but her MRI scan shows 6 T2 lesions, cortical, periventricular with no GAD enhancement, and no brainstem or spinal cord lesions, so she was given a diagnosis of relapsing remitting MS. She's willing to discuss therapy but cautious about what treatment to choose and wants to think about and discuss her options. So she's engaged to be married, and she'd like to start a family in the next few years. Not of that.
Okay.
Please indicate which of the following you would prescribe to Katie as a first-line treatment. So out of all of our responders, it looks like 49% of them chose Copaxone. 21% chose Tecfidera and 12% chose Aubagio. You can see the rest there.
Can I make a comment here, Margaret? It's Virender Bond.
Yeah.
Yeah. So the problem with this is that, in real life, you're kind of forcing the neurologist to say which one. And in real life, we always have, a couple in mind, and then for a variety of reasons, we, go down and zero in on one. So I just wanted to bring that up. It'd be nice to kind of have that leeway, but I don't know how you could do that in a setting like this. And always be conscious of the sponsor bias. I think that's a comment that I'd like to make.
Right, for sure. And I think we did have some discussion about that as well as faculty about sponsor bias too. So I think we're going to go into a little bit more detail with the slides as to why you would recommend this or what you would think about this.
Yeah.
So this is talking about the primary reason that you selected your first-line treatment as they did for Katie. So as you can see, out of the 33 neurologists, 78% of them said that family planning was a big consideration because she's indicated that she's just going to be getting married and she's planning on starting her family. 17% looked at disease severity as a reason for choosing that medication, and 5% said it was the safety side effect profile.
Sounds fine.
So any information available that would cause you to select Copaxone for family planning? Or what information is available that would make you think to choose Copaxone for family planning?
Dr. Giaconi, it's relatively safe if she got pregnant, but you can stop it. You don't have to remove it from your system.
Right, and we had some discussion about the category classification when a patient, sorry, I just have to look to my notes that I took that day. Is it category
C?
Yeah, so it's a little bit safer than the other ones.
That's right.
Perfect. And is there any information available for the other agents that you would possibly choose?
Well, none of them are really recommended in pregnancy, so you would hopefully counsel them to make decisions, decide what they're going to stop the medication before they plan on starting a family. And you wouldn't pick Aubagio because you'd have to remove it because it can stay around for a long time.
Right, correct. And, that's sort of one of the things that we focus on in our clinic is say, if you are planning to start a family, we'd just like to have that part of that discussion so we can sort of plan it a little bit more safely. Now, does anybody else have any other discussion points that they'd like to bring up?
But in the last, Dr. Cote, do you hear me?
Yeah.
Okay. So in last discussion that we had in Quebec, there is no so bad problem with Aubagio, even if there were something in the information that we have before. So certainly, Copaxone is the best treatment if you are pregnant because you don't have to stop. But I don't say that you cannot prescribe Obadjo or you cannot prescribe Tecfidera. You just have to stop when she's pregnant. That's it.
Oh, no, Obadjo, you'd remove it from the system with the...
Yes, but I mean, if she plans to be pregnant, that doesn't mean that it will happen next month.
So yeah, the problem with that, here is that if the patient tells you that now they would like to, you can stop Obadjo, you can then wash it out of the system. It's a little nuisance, nothing major, you're right. But the trouble is when the person announces that they are pregnant, so they're already 3 to 4 weeks into it, and then...
But even then, the last data shows there was no difference between Obadjo patient and the others. So I think that we have to be more careful about to say you can't be pregnant. You have to be careful, but that doesn't mean that if you are pregnant that you need abortion.
No, it's not that. But you have to, mention that the animal data did show teratogenicity. And it's true that thus far, human pregnancies that have occurred, there has been no teratogenicity. But you'd be standing on kind of thin ground to defend yourself.
But all drugs that we use for MS patients, it is recommended that never be pregnant. You are supposed to have 2 methods of contraception. Nobody do that.
I know, and people forget.
That's it.
Mm.
So when I discuss with the patient, I said, if you plan to be pregnant, probably Obadjo is not the first course, the first treatment that I would recommend. But I think we have to explain all the things, and we have to tell the patient that if you are on Obadjo, you can have some treatment, and we can eliminate from your blood before you be pregnant. But, I mean, if it happens, we'll see.
And the other comment I'd like to make is that the Copaxone, even though family planning or planned family planning stands out as a big one, I think the fact that we don't have to do any monitoring and proven long-term safety, they all are in it together to make it, high percentage.
So it's a good conversation, and that's useful to have in the events that you'll eventually be running. So thank you for that. Margaret, do you mind moving on to the next one?
Sure, no problem. So this was hypothetical case number 2. It's a different Phil, a 36-year-old carpenter, right-handed, referred from the ER with subacute onset of an unsteady gait, unable to work on construction job. He is dropping tools and considered unsafe. Less than 6 months ago, he developed gradual weakness and stiffness in his left leg, difficult to control. He is better, but he still feels the stiffness. He has been previously well, no comorbidities, born and raised in Canada, adopted, does not know his family health history. Neurological exam reveals no overt cognitive problems and normal cranial nerves. Mildly weak and spastic left leg with 3+ deep tendon reflexes and upgoing left plantar. Ataxia dysmetria of the left arm and leg with wide base gait, EDSS 3.0. MRI brain and spine scans reveal 1 non-enhancing cord lesion at C3-4, 15 T2 lesions in the brain, including 1 GAD-enhancing lesion in the pons, as well as in a left cerebral lesion. So he's diagnosed with relapsing remitting MS, discussed the prognosis with the patient, and he is very eager to start therapy. He has no benefits and he's now unemployed, and therapeutic options discussed, including sequencing strategies. Well, when the neurologists were asked, they were asked to please indicate which of the following you would prescribe to Phil as first-line treatment, and 64% responded with Tecfidera as the first-line treatment, 24% with natalizumab, and then the remaining medications, as you can see there.
Is that patient has some spinal tap?
I'm sorry, can you say that again?
Is that patient has some spinal tap?
It doesn't look like there was one done, no.
Because for me, that patient has PPMS, it's not RRMS, so yeah. I don't think that we need any treatment or that treatment.
Yes, I agree with you. It sounded like primary progressive MS.
It does present like that, doesn't it? For sure. So we're going to go.
I mean, did the patient receive treatment with steroids and see if there's improvement, or?
We don't have that information, no.
Okay.
Yeah, but I think you would have to say something about steroids and a dramatic improvement to make people think about this as relapsing. Otherwise, your next question is going to be difficult to spend.
How do you get Tysabri as a first-line treatment in Canada?
In some provinces, you can.
In Quebec, you can, but not in Ontario.
No, and in Atlantic Canada, I used to. In fact, 10% of my Tysabri patients were therapy naive. But now out on the West Coast, I know it's impossible.
We're not able to get it as first-line therapy either in Alberta, second line. So, well, you know, it's we don't have all the information, so we'd certainly get more. Ask if this patient was treated with high-dose steroids, and certainly rule out the possibility of PPMS versus relapsing remitting. So we're just going to go with relapsing remitting because that's the way that the questionnaire was formatted. So, and then they were asked the primary reason that they selected this first-line therapy for still, and 67% said it was because of severity. 21% responded as efficacy. So
yeah,
sorry?
I said, yeah, he's a worrisome patient because he's male, he's cerebellar and pyramidal tract, so he'd be some patient you'd want on an effective treatment.
Exactly, for sure. So what information is available that would cause you to choose one first-line agent over another for this patient? I don't really understand.
I think that these two patients are totally different. So you cannot compare that two patients and the treatment.
Of course they're different.
I agree.
We're not comparing them.
Yeah. Comparing the two patient cases, why not select a treatment based on efficacy in case one, the 27?
It's because they don't have the same disease.
True. Yes, exactly. Then we put in this article here that was suggested by Dr. Parks as, you know, looking at disease efficacy and delaying disease progression. So it's actually not a bad read. We're familiar with it.
Yeah,
so just to jump in for a second.
Pardon?
Oh, sorry, I just spoke over top of someone.
Go ahead.
Just to jump in for 1 second, that second case that it sounds like the group thinks it was more primary progressive. I did get that from one of the faculty, Dr. McKenzie, and he did present it as an RRMS patient that he has seen recently. I don't have the details. I was just trying to look it up quickly as you guys were speaking about whether it was treated with steroids and what happened, but that was presented as an RRMS patient.
No, so we realize that, but from the, you know, the questions that follow, but I think one needs to modify that slide and, you know, talk about these steroids, and I'm hoping a robust response. I don't think banding really would help one way or the other, but I think it's important so that unless the slide is meant to have a discussion what type of MS it is, I think the discussion is this is a relapsing remitting MS with a polyregional presentation, incomplete response, cerebellar involvement, cord lesions, high MRI load, and therefore a totally different patient profile than the first case.
Right.
Yeah, I think without clarifying the time of onset, the heart, if it's kind of gradual, then really it leads you to primary progressive MS. Then it defeats, I think the idea is to present high burden disease in without you remitting. I think the purpose from this training.
But sometimes we don't want to label people with this on the first, the first assessment, and you review the history, and maybe you can tease out a minor episode before that got better, and then you will call them relapsing remitting so that you have access to some medication, and you look going forward whether they behave like a preventive disorder without. So yeah. You may have presented it so that you would put this person in relapsing remitting so you have options, and then going forward, determine whether whether the patient behaves like that.
Totally agree. And in fact, in a perfect world, if we weren't, if the payers didn't decide on what's first line, second line, you wouldn't worry about the confusion. You would probably treat this person with ocrelizumab because both types of MS would be taken care of.
I totally agree.
But that's not going to happen.
Agree. Yeah. Hopefully, one day these criteria will change.
Right. Yeah.
True. Very true. So, again, they were asked in the past year, what was the first-line medication of your choice, ranked as a first option? The first 46% responded with Tecfidera, 27% Copaxone, and 24% Aubagio.
Mm-hmm.
So, and then,
excuse me, but I agree with that. But in Quebec, next week, Copaxone won't be covered anymore by the government insurance, and we will have to prescribe Latec.
The same became in Alberta effective July the 2nd. So we're experiencing the same thing, and when we developed this program, it was before that came down. But you're right, it's going to change prescribing practice.
I didn't hear what he said. In replacement for Copaxone, what do you have?
The generic, the Latec.
Oh, the generic, yes, or the 40 milligram. Although probably the 40 isn't available.
No. Yeah, so this was all done before that.
Is that a bad thing, the generic? Do we think it's a bad thing? We don't know.
No, I don't think so. I think.
No,
we don't know what the response will be.
Yeah, we haven't had a lot of experience with it in our clinic, to be honest, because it's so new. So we're kind of holding our thoughts on that for right now.
And will Teva supply Copaxone, the brand name, for the same price as the generic, or like other companies?
No, that's the reason why provinces are going with the generic, because Teva is keeping the price as is.
So they're not sort of modifying down or reducing the price.
No, from what I know, no.
But they present Latec not like a generic, but like an bio
equivalent.
Yeah.
Isn't it called subsequent entry non-biologic? It's sort of like a fancier name for generic, but it's not.
Right.
It wasn't tested in any studies, right? It wasn't tested.
Oh yes. Yes, it was. Yeah.
Whether like a regular study?
Yeah, it's
yes.
I forget the name of the study.
I forget, but it was tested.
Yeah.
So just in the interest of everyone's time, I suggest we move on. We've got quite a few slides that we still have to get through, even though I don't want to shut down this conversation.
Okay.
Thanks. Okay, so then we asked them about what interval they would usually see their follow-up with their MS patients on a first-line BMT. So for mild disease activity, 12% would see them every 3 months, 45% for moderate disease activity, and then 61% would see them every 6 months for mild disease activity and 52% for moderate. So everybody's a little bit different, and I guess it depends on availability in your clinic. So that was sort of the synopsis of the neurologist, the feedback we received from them. So this is a patient assessment, and so we had 314 patients that were part of the assessment. So the inclusion criteria for this was that the patients were on their first MS therapy, and they were receiving one of the following first-line therapies: Aubagio, Avonex, Betaseron, Copaxone, Extavia, Glatex, Integrity, Rebif, or Tecfidera, and the patient had initiated this first-line therapy within the last 24 months. So our demographic here was, average age was, of our 314 patients, was 38 years, and 24% of those patients were male. The patients were diagnosed between 6 months and 5 years, and 31% of them were in the 1 to 2 year range of diagnosis, 23% being at less than 6 months. So a really good range of patients. So this slide looked at how much time had passed between the diagnosis and the initiation of treatment, and 25% responded less than 1 month, and 48% responded in 1 to 6 months, which I think is probably about an average, and certainly what we see reflected in our clinic here. So they asked indicate what the following factors influence the time of diagnosis and treatment. And, you know, a lot of the times it's patient preference, which has come out the highest at 38%, and we certainly see that. Sometimes it's getting your vaccines updated or testing requirements for other reasons. Reimbursement is part of that as well. So I don't think this is an unusual finding for any clinic. And one of the things was, has the patient recently been in contact with any potentially opportunistic infections such as tuberculosis, and 88% of the people responded no, or there was no information. And then how did the patients present at diagnosis? And interestingly, 60% of the patients were monosymptomatic, and only 37% had polyregional syndromes. So how does this patient presentation compare to your current practice? And how does it compare to your practice from 10 years ago? Those are sort of our discussion points.
I think that reflects my patients. Of course, many patients are referred because of MS. That means that they have the imaging before, and they come to have a official diagnosis and to begin the treatment. So.
And are you in a university setting or a private clinic?
No, I am a private clinic. Yeah. But I am about the only neurologist in northern Montreal who has a MS clinic, because in hospital near my clinic, the MS specialist went to another city. So many patients now, they are referred directly to my clinic.
Okay. And would you say that this is fairly similar to 10 years ago, your practice, or has it changed?
I won't say it changed, because I've been there for more than 25 years now, so everybody knows that Dr. Cote is specializing in MS. So.
Excellent.
But Jean-Pierre, the question is that 10 years ago, would most of your patients had started the DMT within the first few months?
Yes, I always be. I never wait to begin any treatment. I was more active since the beginning, and I always follow that since more than 10 years.
Mm-hmm. Good for you. No.
And I would say for RRMS patients, maybe 98% are on medication.
Yeah, I don't have quite that high rate, because I have a number of patients who like holistic approaches and don't want to go on, or have to think about it, or have, you know, misguided opinions about the drugs. And so I have more patients who on presentation will wait or are reluctant to go on treatment.
And would you say that 10, 15 years ago, there was a little bit more of that?
Well, I think we have more choice and we have oral agents, so I think it makes it more palatable, the options. So I think it's easier to prescribe and convince patients with now than we did with 10 years ago. We were mainly dealing with injectables, and so I think that it's easier to prescribe medication. I mean, there's still each medication has monitoring, and so once you start getting into that with patients, not everyone sees it the same way that you see it. And but I think that the neurologist can present it, play a big role in the slant. And Dr. Cote can get maybe so many people because he presents that this is a serious disease.
If I can say something, I don't have any nurse working with me, so I spend at least 1 hour the first time to explain what is MS, why we have to do some treatment, what will be the monitoring, and I think that this way there is no intermediate between me and the patient. So the patient are totally open to ask any problem about needles, side effects, efficacy, when, how, what to do. So I think this is the way we have to do the things.
That's great.
And I see many patients going from university center to come to my clinic because they never see the neurologist. They see the nurse. They don't have any results. I mean, many doctors just decide to put the work on the nurse, and they don't do their job.
I can't believe he just did that.
But it's a fact.
Good. All right. Anything else, or shall we continue moving on?
Yes.
Sure. Let's continue.
All right. So at the beginning, there was a question of, was an expanded disability status scale done? And 98% said yes, and the average EDSS score was 1.8. And then an SDMT, so 88% said no, an SDMT wasn't done on initiation of treatment, but when they did do it, the average score was 54. So now, did you perform a depression screen at the initiation of treatment? 51% yes, an informal depression screen was given, and 44% said no. And did the patient complain of fatigue at the initiation of treatment? It's pretty much straight across the board. Yes, sometimes yes, often or no. And did the patient have any risk factors, any of the following comorbidities or risk factors at the initiation of treatment? And they were asked to select one or all of them. And as we all know, anxiety and depression are very high comorbid risk factors in multiple sclerosis, and that's represented here. Whereas 49% said they had none of those. So interesting. And was the patient's family planning status, what was the patient's family planning status at the initiation of treatment? 76% said they were not planning a pregnancy, and 13% in the distant future, so not that many. For the patient, sorry?
A quick question, a quick couple of questions there. One is that why choose 5 years? Because it almost makes it a non-issue. You know what I mean? Planning a pregnancy in the next 5 years, would that really affect the initiation or the choice of treatment? I don't think we can go back now, but anyway, that was a comment I wanted to make. And the slide before, did those comorbidities, was there any, and Stuart, maybe you can answer this question too, was there an association between the comorbidities, especially anxiety and depression, and let's say delay in initiation of treatment? Because I think you have that data. you could see, because that has been shown that psychiatric comorbidity, those patients are less likely to even start treatment, and B, if they do, there's always a delay.
Yeah, that's an interesting question. We haven't looked at that, actually. We can certainly do that, though.
We would have that data, yeah.
That's a good point. Just in relation to your other question, or your other comment, I guess, about the planning a pregnancy in the near future versus distant future, that was a discussion I had with one of the faculty as well, where we had sort of said, we initially had 3 years, and they said, well, 3 years maybe is too close, so let's move it to 5 years. So I think it's just a difference of opinion on whether you go to 3 versus 5 versus whatever it is.
But I think that 2 years is usually what we can say as the limit between we think about to change the medication, or, I mean, if you plan to have a pregnancy in 5 years, I mean, probably it won't occur.
Yeah, I mean, when I first started with the prescribing Obagio, the first 2 patients came back at the 6-month time frame and said they want to get pregnant in the next year. So people change their minds. So I think even when you talk about they have no plans, so picking a long window is not realistic, and people come to different decisions at and using a long window is probably not reflection of what happens in the real world with patients. So probably a shorter interval is a good idea. And you can
presenting this from the first visit to give them these options to think about it. So when they come next time, they already made their mind if they are thought about planning pregnancy or not, because it's important to start medication. Not every time changing medication depends on the side effect and all that. Or as we know, at least 35 to 40% are non-planned pregnancy. We've seen it in the real time.
But what is very important for me is if you see a woman and she is like 38 and she wants to be pregnant, it's probably much more important for her than if she is 20. She will have more time to think about it. So it's not only the years, but at what age the MS is diagnosed.
I agree with that, and as you know, later now most of the women are getting pregnant late, over 35, and because and they're into high-risk pregnancy. Just without MS, they are high-risk pregnancy. So really, we have to discuss this issue. My other question is when they mention about anxiety and depression, is that was pre-MS diagnosis, or because we have to differentiate whether it was, people sometimes when they get diagnosed with MS, they start getting depressed and all that, or they were already diagnosed prior.
Yeah, it's hard to know because it's very common. Very common in this population, right?
Yes. I think there is much more patients with anxiety and depression in MS than in other patients that I see.
It would be interesting, too, to look at this like 3 or 4 years after diagnosis and see what their anxiety and depression scale is then, if it's worse or the same as when they first initiated treatment, I think, because it is a huge problem in this population.
But anyway, they have to be treated.
Exactly.
For anxiety and depression.
Yeah, exactly.
Related or not to MS, they have to be treated.
Right.
Okay. Then there was a question asked, are we okay to move on? Sorry.
Yeah. Go ahead.
So were the patient's immunizations confirmed to be up to date prior to the initiation of treatment? 25% responded no, and 35% said information not available. 40% said yes.
So what comprises immunizations?
Varicella zoster, maybe?
Is it just zoster, or is it Hep B, or is it, I mean, you can if you include more and more, those numbers may change. I wonder what comprise immunization.
Yeah.
Great.
That TB, yeah, I agree.
Do you have any of that information?
But I would say in Quebec that all teenagers, they have immunization, I would say about everybody. So until they are, I would say 25, 30 years, many of patients have all their immunization. But the people between 30 and 50, 55, they are the people, most of the time, they never have been all the immunization that we need to know if we think about Gilenya or Ocrevus or other things. But for the first line, it doesn't matter.
Right. But I think this is a changing field, and I think that when we're going to start embarking on treatment with patients, we're going to start looking at their immunization schedule so that we don't have to do it, so we know what the options are and we have it at baseline. So I think that whatever we've done in the past is going to change because of these newer agents and what we have to check before we initiate them. So I think things will change a fair bit, and we'll probably have more standard protocols of what's being checked, because previously we didn't check too much except for maybe Gilenya. But now with the other agents, as you pointed out, you'll need hepatitis status and others, and you may have to give, vaccines.
And for me, a new problem is, that the patient has to pay for that immunization, for hepatitis B, for Zona, for...
Yeah, that's right.
I mean, I think it's a lot. It's more than $200 and $300.
Yes, yeah, that is a barrier for some people. So, but hopefully they'll be immune to it. But again, you may want to vaccinate them separate from whether they've been exposed to zoster. You may want to vaccinate them if you're maybe not for the first line drugs, but certainly when you escalate therapy, this is more important too. I think different MS clinics have different protocols, and some have very extensive immunologic, questionnaires and look at this a lot more systematically. I have a general neurology practice like Dr. Cote, so this is going to change in my practice based on the newer agents, I think.
What we do with our newly diagnosed patients in Edmonton is we get them to go to the public health unit. For example, if they're taking a Baggio, we get them to get a TB skin test, and often their immunizations are updated at that time, making sure tetanus, DTaP, pertussis, all of that stuff is up to speed. And I think that we're going to continue to do that so that we can identify people that haven't been immunized for whatever reason, or they're lacking immunization, then we can get that started before they even go on to treatment. We're going to need it as we escalate therapy as we go along.
When did that wasn't part of when we started these agents as a requirement. When did that change? I notice people are doing that now. When, and what is the evidence? Is it something because of the escalating therapy, or is it something to be concerned about with the older agents?
No, I think it's because of in the intended escalation. There have been a few instances, and I've been involved with one or two myself, where, for example, let's say a patient is failing Gilenya, and you're going to go to a more potent drug, and you suddenly realize that, so you stop the drug, and it's true of both Gilenya and Tysabri because you're worried about rebound, and then you realize before you go on to the next agent that this person is not zoster immune. For some reason, didn't get chickenpox as a child, and now this would be outright dangerous for them to go on to, let's say, Lemtrada or Ocrevus. And then you're going to immunize this person then and wait, and in that time, the MS disease can come back, and in some of these patients, and the ones that I'm talking about that I was involved with, had rebound, and that can be quite significant.
Because in Ontario, I mean, when I started Gilenya, this was part of the program was to check the immune status on everyone before you on it. But I get because of this contaminated zone.
Yeah, it's because of the sequencing and because of what you're going to do next.
Yeah. Well, I think that it makes sense to do was it Margaret that said that we should be checking this, for other health reasons, that, if we have an opportunity, and
exactly.
Most of us are not doing TB tests in our practice. There's no reason why not to check all the appropriate age-appropriate vaccinations so that we have less to worry about.
Yeah, agree.
Good luck getting an appointment with a family doctor. I mean, I think they can see me faster than they can see a family doctor, but in some places. But anyway, that can be a barrier too, because there's often waiting, and people don't have family doctors too. So you have those issues. But
true, it's very complicated. Not quite so easy as to go to the public health unit and get your immunizations updated. So, all right, we'll move on then. So how would you rate disease severity at the initiation of treatment? 48% rated it as low, 43% moderate, and 8% as high. And what was the number of T2-weighted lesions at the initiation of treatment? And we can see that for low disease activity, there was 44% for 6 to 20 lesions and 54% for moderate disease severity responded for number of T2-weighted lesions. So everyone kind of has a different idea. And what was the number of gadolinium-enhancing lesions at the initiation of treatment? Low disease severity, 59% responded, 37% said none, 14% said low disease severity had one or more GAD-enhancing lesions, 36% for moderate or high disease severity, and 27% equally for low and moderate with GAD-enhancing lesions.
Does everyone do a GAD-enhancing MRI, or do they just do a standard MRI?
I do with GADO at the first, but not on a regular basis.
Because it certainly, it has to be done during the day, and it extends the waiting time considerably if you, if you, because they can do non-enhanced MRIs after hours, and they can't do it, so it does extend the time.
But they don't have to have two. They have only one, and we know.
Yeah.
And we don't have to repeat in 2-3 months.
Yeah, and our hospital depends who's the radiologist and how many arms you twist. Ideally, we try to get, gadolinium enhancing so you'll know where, because sometimes that will help with diagnosis without going through LP, especially if they present one clinical presentation.
So you're doing it to is this to distinguish CIS or RMS, or just acute recent activity?
Some of the patient, yes, and some of the patient also disease, burden of the disease, because some patient you do it and you see they have 7-8 enhancing lesions. So, that's it change your, the sequencing and all that, and what you're going to start them. So it's helpful, but also, you're under pressure of the, the resources and the radiology department, and your MRI scan, is it down or not, and all that. So especially I work, in a satellite unit from Dalhousie here in Sydney, Nova Scotia. So there's,
I think it's important to have a chat with the radiologist in general that we're not asking for GAD each time we ask for an MRI on an MS patient. It's only at the time of the diagnosis. So that would be ideal. That's something to strive for. But if in your setting the GAD delays then the MRI by months, then it's not worth it, right? But otherwise, if you can, first MRI should be, one should strive for GAD with that one. The follow-up MRIs don't have to be, and then once you communicate that to reaffirm them, they get reassured, because otherwise they're thinking every MS patient, every time an MRI is asked for GAD, then obviously that's not a good scenario.
Does that apply to, the low probability that patient has MS, when you're doing an MRI?
Oh, no, absolutely not.
You're talking about, This is for
I'm talking about you said it correctly, because this is the classic CIS where you want to do the GAD MRI because you may get the diagnosis right with one MRI and move on to treatment. But the vague symptoms and so on, no, for the vague symptoms you don't want to inundate the radiologist with that.
No. Yeah, so that's why I don't do it uniformly with any.
Yeah, exactly.
There are MS patients, and there's patients you think, yes, this is going to be MS, right? So,
yeah, those ones, yeah.
Okay, so keep moving on then. So was there any brainstem lesions or spinal cord lesions at the initiation of treatment? 51% responded yes for low disease severity and 78% for moderate disease severity. 45% said no for low and 19% said no for moderate disease severity. Now this is the percentage of patients with brainstem or spinal cord lesions at the initiation of treatment. 51% said low disease severity and 78% said high. The average number of lesions was 2.4 in the low disease severity and 3.0 in the moderate to high disease severity. So that's brainstem and spinal cord lesions. So please enter the number of relapses this patient experienced in the last 12 months prior to the initiation of treatment. So 59% said that low disease severity had one relapse, whereas 20% said they had more than one in the low disease severity, and 52% said that they had had one relapse in the last year and 37% in the moderate to high disease severity over the last year.
So that means 2 attacks, right? Or the initial diagnosis and the additional one, right?
Correct. I believe so, yep. That was in the 12 months prior to the initiation of treatment, and we would have had an attack or 2 to get on to treatment. Did the patients completely recover from the relapses? 70% said yes in the low disease severity and 36% in the high disease severity, and 26% said no in the low disease severity, and 59% in the high disease severity did not recover completely. So in the PACE MS program, there's not always clear differentiation for low versus moderate high disease activity based on patient factors assessed. So what are the main drivers that you measure to determine disease severity in your patients? Is it T2-weighted lesions, GAD-enhancing lesions, brainstem, spinal cord lesions, number of relapses, recovery from relapse? And do you put more weight on one of these factors? And on the right, we have the dial that kind of gives, I think it was Dr. Friedman that came up with this to sort of help decide if the patient was low, medium, or high risk for disease.
Yeah, I'm in Ottawa, so I'm familiar with this, and this is what I look at, all the factors, but certainly major attacks, lack of recovery, MRI, and progression are all the things that we tend to look at. I mean, you worry about spinal cord lesions too because they're more likely to be symptomatic, and polyfocal presentations. So these are all the things that you look at every visit to decide whether you're hitting your targets.
Yeah, we use either this or the Rio criteria. So
yeah, it's similar. Yeah,
therapy.
Okay. I think it sounds like most people are using this, sort of looking at all the different factors. Would you put more weight on one factor versus the other?
I put a little bit. I know that in some places, a couple of T2 lesions doesn't necessarily result in over a year or 2 doesn't necessarily make me escalate therapy, but I know in some centers that they have a very low threshold for switching if there's MRI activity. So I guess I kind of look at putting more weight on clinical activity, although we know it's not always evident. The attacks don't always have clinical manifestations. So the MRI is a little less. Although, you know, if you have a very active MRI with gadolinium-enhancing lesions, if you did GAD, that would make me escalate treatment.
Right.
But I think I agree with your clinical thoughts, is that even though not as frequent as MRI, but when it happens and there's incomplete recovery, in fact, many times that's associated automatically with a bad MRI too. But that, to me, you know, is especially cerebellar or cord involvement that leaves a person with significant ambulation, you know, difficulties with walking around. So that to me would be a big driver. It's also very artificial how to define moderate. Like, you know, it's easy to spot severe and the mild, but in between there's kind of a gray zone that extends quite a bit. One person's moderate may not be another person's moderate.
That's a great point, Dr. Vaughn, and I think you can see that in a lot of the differences between the low versus moderate severity disease in the previous graphs, where there was, you know, there's a lot of overlap in the people that said this is a low versus this is a moderate. So I think it's an important point.
Yes.
For many people, our disease activity is 2 attacks. I mean, for me, it's not really active.
Can you say that again, Jean-Pierre?
I said, by definition, a high disease activity is some people with 2 attacks the last year.
Right.
This is the criteria for MS. So for me, it's not really high disease activity.
So what's high disease activity?
I mean, if you have a patient with many attacks, many relapse, multiple gado lesions, that is high activity. It's not that patient with like numbness and gait problem that you cannot even say if it's really objectively.
Yeah. Yeah, a few years ago we used to talk about the RES-MS, or rapidly evolving and severe MS, and the definition was 2 severe attacks in the last year. And by severe meaning, you know, it's significant involvement of motor or cerebellar system, requirement for steroids, and occasionally even hospitalization. That would be, so you would agree that that's totally different than the, you know, numb foot or numbing.
Totally agree.
Well, we usually can distinguish what a significant attack is. So, and that there's a lot of background transient symptomatology that probably is, you know, unique to MS patients, that we're never sure it's an attack. We don't treat it with steroids. It may be a short duration, and you know, if you talk to MS patients, we hear this all the time, that they have these symptoms, but we don't, you know, Lermit's phenomena, although that probably has a good clinical correlation, and it's hard to, you know, those are, we don't really call those necessarily attacks, although there's some background noise in people's symptoms.
Yeah. Right. All right. So the question, so what is the primary reason you selected the initial treatment for the patient? So for the discussion, how do you think PACE-MS participants responded to this question? Do you think they chose disease severity, efficacy, or any one of those? How do you think they would have responded?
Efficacy and safety, I think they would look at.
Yeah, I think safety and side effect profile would be high.
Yeah, I agree.
Yeah.
This is how it's out. So disease severity was one of the top ones. So for low disease severity, that's in the blue, 53%, and moderate was 55%. Efficacy was higher in the moderate disease severity grouping, and side effect profile was lesser in the moderate disease severity grouping. So interesting outcomes there. But notice that it also says patient preference was 59% in the low disease severity and 57% in the moderate disease severity. So interesting outcomes. I thought that was really appealing, very much in keeping with what we do in our clinic as well.
Well, MS is unique in that we present them a menu of what they want to try. And most of the time you have, otitis media, you give them an antibiotic, but in MS we empower them to participate in the decision. So I'm not surprised that patient preference is prominent here because we're giving them, well, many times we are giving them choices.
Very much so, and sometimes the patients just can't make that choice on their own. They really need some guidance.
It's not defined here, but patient preference itself is a compound, endpoint. In other words, why do they prefer? It could be the mode of administration, it could be safety concerns, it could be the follow-up that's needed, and so on and so forth. It's worth kind of exploring this, not here, but I'm just saying it's not one thing, the patient preference.
Right, exactly.
And I can put some emphasis on family planning is not really a problem. It's not a concern for the patient.
Right.
Also, patient preference can translate to compliance. If the patient is comfortable with the certain medication, you know for sure they're going to be compliant, and then get the result from the medication.
Yeah, which is the main reason why in MS we kind of get them to participate in the decision making.
Yeah.
Okay.
Okay.
What was the primary reason you selected the initial treatment for the patient? So again, right to the bottom of the graph, 31 and 32% both said that it was patient preference. Next was the efficacy and disease severity. So I think that's sort of well. Someone have a comment? Sorry, I thought I spoke over top of someone. Okay.
No.
Well, when prescribing
isn't there a disconnect with the first hypothetical case where neurologist said family planning was a big deal, and now all of a sudden it kind of has shrunk?
This is why, Virendra, I told you. I think it's not an issue.
It's important to remember as well that these patients, in that hypothetical case, I believe the patient was 27, and the average age of these patients is about 38. So they're a little bit older, potentially past that point, or more of them likely are past that point where they're thinking about family planning.
That would explain it, yeah.
Explain the answer, yeah.
And family planning and getting pregnant isn't a bad treatment.
All right. So when prescribing the initial treatment, which best describes the approach that you used? So 16% responded that they discussed some options with the patient and then prescribed what I thought was best, the best one for him or her. 61% said they discussed options together and made the decision together, and 23% said they discussed some options with the patient and then let them choose. So I think that's very in keeping with practices, is that we discuss it with the patient and make the decision together, shared decision making.
Yeah, that sounds about right. We agree.
I agree.
So what was the primary reason that the patient wanted the treatment that they were prescribed? And 63% in the low disease severity came back as a safety and side effect profile, which I see a lot of in my practice. 48% in the moderate to high disease severity looked at safety profile. And then mode of administration came out very high as well, which also makes sense. And efficacy was in there as well for the moderate to high disease. And in keeping it was higher in that grouping than the low disease severity. So interesting.
Mm-hmm.
The primary reason for the treatment selection was, again, side effect safety profile by the patient. and then it was efficacy by the patient as well as mode of administration. So those are all things that we see every day with our patients, as I'm sure you do as well.
Yeah.
So out of all of that, the recommendations that come out of it are early intervention in MS is vital and needs to involve people with MS proactively in shared decision-making and the management of their disease. So aligning prescribing guidelines with the latest accepted diagnostic criteria to give people with MS the opportunity to start treatment and receive support promptly as soon as diagnosis is confirmed. Ensure that MS healthcare professionals can take the time to educate people with MS about strategies to manage their disease, emphasize the importance of a brain-healthy lifestyle, the benefits of early treatment therapies that can modify the disease course, the likely consequences of inadequate or suboptimal treatment, and the goal of minimizing disease activity while optimizing safety. Implement a shared decision-making process that embodies the dialogue between people with MS and healthcare professionals. A well-informed and proactive collaboration between people with MS and their healthcare team is vital to successful management of the disease. Make the full range of disease-modifying therapies available to people with active relapsing forms of MS, regardless of their treatment history, to speed up adoption of the most appropriate treatment strategy that optimizes effectiveness and safety for each individual. And seek regulatory and health technology assessment approvals to implement these recommendations. So, discussion questions. Patients select safety while healthcare providers select efficacy as the primary driver for treatment selection. How do you ensure that you're presenting treatment options without introducing bias in one way or another? So if you were treating a patient who was a neurologist, would you suggest the same treatment options? And then the second part is, for patients with significant disease, do they consider sequencing at the time you choose their first-line DMT?
So remind me what you mean by sequencing.
So it would be like, you know, we have first-line therapy where we have to start with our base therapies, like and we upscale or escalate to Gilenya and the rest of them, natalizumab, alemtuzumab, those drugs. So, yeah, we don't, in our clinic, we don't talk about sequencing when they're choosing their first-line DMT ever. We only just talk about first-line therapies.
But and then in a very severe patient, you may not go with the first-line treatments, but try to get the escalated therapy as the first-line treatment. Is that right?
Well, sometimes we do, but it's difficult because of the way the insurance works. You have to really start with baseline therapies, but for those severe cases, we do sometimes go right to natalizumab for sure. Try that.
I attended some meetings in Quebec City a few weeks ago, and I was surprised to hear that many doctors choose some first-line DMT because they don't believe it is working, and they have the possibility to switch to a second line as soon as possible.
This is true. I've heard this too, and there may be some kind of perverse logic to this, because unfortunately we're forced to use our potent drugs only when the first line has failed. So some people say there's no harm in using your weakest drug so that you can get out of there as soon as possible and get on to what you really want the patient on.
How long does one have to try a first line before going to a second line?
Few months.
A few months?
6 months.
It's 3 months.
Yeah. But I mean, we have, sometimes we're filling out the forms, and sometimes we have a little bit of latitude in how we fill things out. I mean, we have, these drugs work reasonably well in, a moderate number of patients. So even if you pick, a perceived less effective medication, it may get some benefit. but each of us have our opinions of which medications are more effective and which ones we would choose. And I'm not surprised that neurologists would choose efficacy. And probably if we were treating another neurologist, we would listen to the opinion of the neurologist, and the neurologist would probably know what MS is like and would probably be, you know, as a neurologist, I would want an effective treatment. I would put up with more side effects if I had a more effective treatment, because I don't want the disability that comes with this illness. So, but I guess there's individuals who have different perspectives on this.
Right. Yeah, I agree.
There's no free lunch, so you know, sometimes you have to take the good with the bad. Yeah.
True. All right. I think we're getting close to the end here. So what was your initial treatment of choice? 46% in the moderate disease severity said Tecfidera, 21% in the low disease, whereas the higher 32% would pick Aubagio in the low disease severity, and Copaxone was sort of right behind, so it was the top three, 2 orals and Copaxone.
And that slide really reflects patient's preference, because it's the orals that are winning here, right?
Oh,
it's really encompassing patient's preference. Why I mean, Copaxone because it's perceived very safe, and the orals because patients prefer orals to other modes of administration.
Right, exactly. So the next one.
I have a question about the Extavia for the group. Personally, Extavia is a drug that I've not used, and I see here that it seems others are not using Extavia as well.
Yeah, that's true. I mean, hardly ever is prescribed.
Mm.
I haven't seen it prescribed in the 4 years that I've worked here, so.
Okay.
Or even Betaseron for that matter.
Yeah, same thing.
Okay.
Same.
So at what approximate time interval do you follow up with these patients? So they're different colors. Blue is dimethyl fumarate, pink is glatiramer acetate, yellow is teriflunomide, and green is interferon. So every 3 months, but it seems like on average it's about every 6 months, and some people even go out to every 12 months. So it just depends on availability of yourselves in your clinic. So the next steps then are to do a clinical audit tool, optional, eligible for 3 credits.
Margaret, I can do this part.
Yeah.
Thanks. Sorry, I realized this is more for me. Yeah, thanks for that presentation, Margaret, going through the data, and thanks everyone for your discussion throughout. That was really useful, and I hope it's prepared you for your own meetings. Just now, I want to go back into your role as participants in PACE-MS. There's a few steps that you can complete in follow-up. So there's a clinical audit tool available on the platform. This allows you to get eligible. It allows you to get Section 3 credits for the Royal College for your participation in PACE. So if you're interested in completing it, it's optional. You can go on and you can get Section 3 credits, and it's basically you review your own data compared to the aggregate, and there's some faculty feedback built in. The second part is there's a program evaluation and a general results review, and all of these are done on VivoMap. So, you know, maybe starting tomorrow, if you want to go in there and complete the clinical audit tool, complete the evaluation on the program, and review the results, should you wish to, that's helpful for us in getting the evaluation data, and we'd like to be able to give you back the opportunity to get credits for the program. And then I guess just some final thoughts on the program and the data that you can bring up in your meetings. Based on this data, is there anything you'd like to know about your own practice, or is there anything you'll question or potentially even change? And then what indicators would make you think about selecting a first-line agent based on efficacy, I guess, as opposed to letting the patient who might select based on mode of administration or something potentially that you don't agree with? I know there's shared decision-making, but just some sort of prompts there for you.
Certainly, I would change the second case because
oh, yes.
for me,
that's a very important
It's not RRMS for me. So
I agree.
Half of the cases are unbelievable.
For the sake of this program, because you don't want too much time wasted on discussion whether it is RRMS or not, because the point is you want a case with RRMS. So you have to even artificially modify this. So
just throw in
after that.
Throw in an optic neuritis a few years earlier, and then you're
yeah. And then,
then your secondary progressive MS, but it's closer.
Yeah. No. We'll say even with this account there was a little improvement. Yeah. So optic neuritis a year ago, yeah, that would make it.
Then you would feel comfortable calling it that, even though, and when we see that all the time. I mean, this is the 5%.
It's a real case. It's a real case, but for the sake of this, you don't want to, because it's a finite time presentation, so you don't want the discussion to be hijacked about something like that.
That's right. I agree with that.
Or specifically the symptoms.
Yeah, Stuart and Margaret, in the third slide, in the objectives, one of the objectives is map the current treatment landscape to determine how patients are being sequenced. Did we really do that?
For the list of medications that are tried. That's the sequence, isn't it?
I guess it's looking at the first part of the sequence, not necessarily looking beyond first line.
Right. Apart from that one slide where we said, does sequencing come into your mind when you're selecting the first agent? There's nothing here in this entire data set that speaks to sequencing.
Sequencing and how to do it. I agree with that.
Yeah. So, it's because it's one of your major objectives, but it's not really dealt with. So you may want to take that back to the faculty and think about that.
For sure. That's a good point. Anything about the second bullet point here?
Which one?
Indicators that would, make you think about selecting a first-line agent based on efficacy.
We don't have a lot of head-to-head trials. They're different trials, so it's difficult to say exactly. The earlier trials, the patients were more advanced and had more MS before they started treatment, so it's really hard to know which is a clear winner of the first line. So, and then that's probably why we give patients allow them to participate in the decision, because if there was a winner, everyone would be given that drug. I mean, everyone would be on Tysabri if it was safer, as first line. But I think we all have patients that do well with each one of these agents. Maybe not beta-serin because no one's prescribing it, but there are patients that can do well with any of these agents. And there's people that don't do well on many of these agents too.
I think it's a question more about what indicators would make you think would be, not necessarily severe, but an active patient. So that this is
the same way we profile patients, the ones we're worried about, the male patients, the cerebellar, the pyramidal tract, incomplete attacks, short interval between attacks, incomplete response to steroids. So, those patients we know, and we know from the attack, someone with a major attack, you worry about that patient from the get-go. Even if they have a good response, if they've had a major attack, those are indicators that would, I don't say bias us, because we're people ask you, what would you do if you were me? That's not a bias, that's your opinion. They don't have to follow it. I guess it is a bias, but it's also, they're seeking guidance based on your experience with this illness. So we're constantly our opinions. That's what they come to us. So we can present things in a different way. We can massage a little bit which treatment we are in favor, and I don't always present every drug. I go give categories because try to buy glasses when there's 5 pairs of glasses to choose from. It's not easy. So, or 6 pairs.
I'm sorry, I will have to go. So I say bye-bye to everybody.
Nice job, Pierre. It was nice having you.
Okay,
Thank you for joining, Dr. Cote. Thanks for everyone's discussion tonight. Margaret, I appreciate you going through the presentation. Dr. Bond, I appreciate your commentary as well, and everyone participating in the discussion and in the PACE program. So, yeah, thanks very much.
All right, thanks.
Take care.
Okay, good night. Bye-bye.
Bye-bye.
Okay, thank you. Good night. Bye.
Good night.